So I might ask us, because we were having a really interesting conversation around context, because each of you, both in terms of the work you do, but also where you've come from. So Rowena, I might start with you to ask you just to provide a bit of background on the context in which you're operating.
Thank you, Angela. I'm very privileged to live and work on Gundi Jamara country out west. So when you get to Western Health, there's still more west, everyone. You keep going down that Western Highway. So I'm fortunate to be the CEO of Western District Health Service and Casterton Memorial. Casterton Memorial is a small rural health service. So it's a 4-hour drive. So I live in my community. I am the community. We don't talk about the community if it's someone else, because it's us. It's my partner. It's my father-in-law. So to put that into context, when we start talking about equity, I could talk all day because I see it every single day. I see it at the footy club. I see it at the supermarket. So I just wanted to give you that context because you didn't boo and hiss when you said the leaders are in the room, which is a good start. But we really do want to believe in all this, but there's a lot of things that need to sit around us to make these things happen. But I think we've already got an equity problem where I live. And to add on another thing, we've really got to think about how that adds to the suite of what we do and make sure that there is true equity when I think about people who just aren't getting screened for their cancer. And the other thing I'd say is first available GP appointment is 12 weeks at the moment where I am. So even if you present unwell, you're usually coming to the emergency department to seek care. So that's why I wanted a bit of context for you.
No, and I think we'll come back to the question of equity as we go. Eugene, I might ask you for a little bit of context.
Thank you. So my context is being Chief Executive of Monash Health. We have some highly specialist services and we are in the Southeast Melbourne Growth Corridor. And what belies that is the fact that we have a very diverse population that we're looking after. And I agree with the issues of equity. I think that the trade-offs that I have to deal with are the people waiting for care vis-a-vis the benefit for people who are getting genomic-related care. And I think that it's an absolute travesty that we have people getting their stage 4 cancers diagnosed in the emergency department. That speaks to a failure of health, I guess, and there may be many reasons for that, but also the fact that we are probably focused on what we need to get through today as opposed to how we build capability for delivering health tomorrow. The cost, and I'm fascinated by this because the cost is one-off, right, in terms of genetic testing, and it is expensive. It's horrendously expensive. But I also think there is the opportunity for us to start tailoring how we treat people to who they are. And I guess I'm a firm believer that there is an absolute place for genomic care and the tests that come with that. And if I can contrast where we are now, where we are responsible for a number of specialist services in Monash, and how we run the genomic tests and services is down to some really keen, really dedicated clinicians, and it tends to be really niche, right? It tends to be niche, and niche does not mean it's not important. It doesn't mean that it's not effective, but it's niche. And if I was to contrast that with my previous role in Bristol, where we had, I don't know if they still have it, quite frankly, a lot has changed in the last week. NHS England ran the genomics screening for the whole of the NHS. So we're talking population of 77 million with central coordination. And you would have regional centres, of which Bristol was one for the southwest of England and for Wales. And therefore the issues of equity are not resolved, but you have a wider lens in terms of the impact of genomic care, the spread and the reach, which I'm challenged by at the moment because we know what we know in our catchment and in our organisation, but there is a lot that we don't know, and there are a lot of people who we're not reaching.
Thank you. Adam.
Thank you. Good to meet you all. Apologies if I'm squinting. The lights are very bright. It looks like a dark auditorium in front of us. As was said in part of the introduction, I'm CEO at Alfred Health, but actually I've only been there about 8 months, and prior to that I was CEO at Austin Health, and I've been was on the Melbourne Genomics board for a number of years. Thinking about this panel session today and just reflecting back on what I've learned about genomics over the past 10 years, probably the first thing which is known much more deeply by everyone else in this room is the potential for genomics around advancing clinical care, individualised treatment plans, improved diagnostic capability. And that, I think the Alliance and many others have kind of really led the way in the introduction of that in a system-based way across Melbourne and Victoria, but also in reflecting the potential for research and the advancement of research using genetic data, and now also aligning that with the use of artificial intelligence as well, and what potential that holds for future as well. And then I think we also have to be cognizant of what some of the challenges are, and Eugene's touched on some of these. There is a cost involved in genetic testing. We need to kind of acknowledge that, especially in the current economic climate where things are very tight. But despite that tight economic climate, we need to find ways to progress new ways of delivering care. We also have infrastructure challenges. You need infrastructure and staff and training to develop comprehensive genetic services. And we've also got to confront, which Rowena touched on, around the equity issue. How do we ensure a level of equity of access to this type of service? And how do we respond as a whole system, particularly now the Alliance will no longer be in place? So how do we ensure it's not just up to individual health services to do their own thing, which will inevitably lead to great variability in what's available in different parts of the state. So there come my initial reflections from an Alfred Health perspective. People will know Alfred Health quite well. About 50% or more of our patients come from outside of our primary catchment. So there's that very much a kind of statewide feel to the services that we provide. Genetics or genomics haven't been a huge part of the offering, but over recent years through Alex Busiatos and others, that started to build up. And I think this is about trying to consider not what the Alfred's role in the system, but how the system overall should structure itself in this space. So thank you.
Thank you. And we really wanted to run this as a bit of a conversation. So because there's some commonality around your context and then some differences. Do feel free to ask questions of each other. I think, Adam, the point you've made, and it's about 10th on my question, but let's start there, because it is an important one about how do we organise ourselves to really embed genomics into the system across our state. Like, what is we talked a little bit outside about is each individual health service, is it a network question? What is it we need at a system level? I might ask all of you to comment on this, and let's, because you might have very different views.
I'll go first because you named me. And I've already probably said this, but I think there does need to be a coordinated approach to this across the system. I think it would be a poorer outcome if we all just do our own thing, because the Alfred will go one direction, the Royal Melbourne will go another, Monash will go slightly different. And I think that will leave probably Western District and many others kind of as losers in that scenario. So we have to think at a system level, and without the Alliance there, so it's incumbent on us in many ways. I do think there's a potential to use the new local health service networks as an organising principle for how we might do this. So there'll be 12 local health service networks across the state. At the moment, genomics isn't being talked about as one of the kind of areas of focus for those, but there's no reason why it couldn't be. And while some of the regional-based LHSNs may need to partner up with a metro for some of the capability, I think if we start there, so it's a consistent approach to how we're starting to plan and organise other services, that would make sense. But yeah, my colleagues may differ. So
I totally agree. So the state has created the Southwest Local Health Service Network, and that was a breakaway, some people will know this, from what was the Barwon Southwest Local Health Service Network. So we're kind of excited, but we also know that we have to partner. We have to. And I think as leaders, we've got to get into that space a lot better than we probably have over years. And I think that if we do some of the work around referral pathways for, say, the rare cancers, I think is starting soon. How do we set a standard of care no matter where you are? But how do we support that local care? Like, I was listening to the previous conversation. I think I've got a paediatrician once a month that comes to Hamilton. How do I support my 1.5 oncologists to have this conversation? I've got some remarkable nurses and other people. So I don't think it's impossible, but I do think we have to rethink workforce and what it means in rural and regional Victoria. But, you know, by crikey, my community deserves it as much as whether or not you live in Paran or Dandenong. So how do we make that happen? And I think there's got to be a commitment from boards and CEOs to say, you know what, let's get this group together called the Local Health Service Network. We know cancer's a problem. Let's put this into the mix. So I think it's also about leadership.
Rowena, not only does your community deserve it, but you did tell me outside that if you don't get it right, they do chase you down the aisles of the IGA or whatever you might have. So both they deserve it, and also we don't want to be chased.
That's right, they do.
Eugene, a thought on how we organise ourselves to sort of embed this, particularly post the alliance?
Yeah, thank you. So the benefit of being the last to speak, you say what they said. And I would add one in that the networks give us an in to coordinate, but I don't think in and of themselves they're sufficient, because we need to work across networks. When you think about the size of our population and the people who would benefit from this, they're not going to neatly fit into the boundaries of our networks. And if you think about children and the fact that you've got 2 children's hospitals for the state, that scuppers that thought. So I do think that it has to be the basis on which we start conversations, but we've got to go across network. And when you think about the whole issue of equity, I think that the size and scale on which we plan for delivery of genetic or genomic care becomes an equalizer. Because the reality here is you would tend to have underrepresentation of low socioeconomic groups or people with diverse characteristics. And that's a problem if the networks do not have a population that reflects the wider state. So we need to think about that carefully. I also think the fact that there are limited genetic services means there will be certain networks where it's a group of health services that have 0. And therefore that network, by virtue of coming together, will not be able to deal with this issue. So I do think we need to spend some of our leadership time and muscle thinking carefully about what this starts to look like, but also be really brave in the way that we reimagine the delivery of this care.
So it might be several elements.
Absolutely.
What one does alone, what one does as a network, and what happens across the state. And that might, across the state, might not be statewide. It might be partnering of... Yeah, brilliant. All right, we'll talk more about that. One of the things, the Alliance has put a decade of very hard work into research, information, awareness building. And so one of the things that, Rowena, you and I were talking about is one of the things that's been produced is a brilliant guide for hospitals. And you said, well, I think it's brilliant. I've had a look at it. I just didn't know it existed. But any reflections on that as one of the kind of instruments or elements that might help us with this embedding?
Thanks, Angela. Yeah, I am contemporary, I promise you. When I saw the toolkit, it made sense. So I think kudos to those who've developed it. But it's not a cookie cutter. It does need to be localised and thought through about what that can look like. And like, I totally agree. How do we play with the Royals? How do we play with other people who are doing great work in this space? But the toolkit helps to start a conversation with local clinicians about expectations. And let's remember, we've got a much more informed community. If you talk about genomics, my farmer will say, yeah, I do it every day with my sheep, right? I breed good sheep, fine micron wool. I do it every day. So it's not a foreign concept to people. It's just about how we explain it and how we actually set it as a standard of care. I drove up with my brother-in-law who's had all of this applied to his acute myeloid leukemia, and he's doing fabulously. But I also know the guy down the road who was late to his appointments, getting access, and he died shortly thereafter. So I know they're all very different cases, but I'd like to see how we can start to at least use things like these toolkits to set a bit of a standardised but localised type of care.
Another end, yeah. So clinical governance issues. What are the things when we've, particularly, from what we've heard so far this morning, what are some of the clinical governance issues that you as CEOs will be considering, but also looking to your leadership teams to consider as well? Eugene, you might want to start only because you caught my eye.
I'll learn to look away. I think that the fact that genetic testing, genomic work is still niche, right, means that it's in the hands within our hospital and hospital network. It's in the hands of a few people. There are a few clinicians who are responsible for planning, developing, discharging this work. And therefore, I'm very grateful that they are there and they're doing this. However, when I look at the things that keep me up at night, this is not one of those from a governance perspective that I just think we need to get this sorted. And I think that's a problem, because not only is it in the hands of a few individuals, and therefore the risk of continuity depends on whether we have those clinicians or not. I also think that the oversight, the guardrails that we need, and indeed the sponsorship that you would give to other issues that are higher up the governance chain is different. And therefore there are missed opportunities in terms of what I and the rest of the executive team can bring to this. And there are also some risks of exposure, because it's not getting the attention that other things are. Now, within the constructs of our organisation, there will always be people who are keeping an eye on this and ensuring that it's connected and we have the right checks and balances in terms of the work that we're doing, and indeed protecting the clinicians and the patients. But it's not one of those things that would have the same sort of profile. So I do think there's something that we need to do about this.
Yeah, and that's a really important issue that I think we also talked about previously. So I guess there's a question about how do we frame this? And it's one of the conversations we've been having. How do we frame, because it shouldn't be niche, it shouldn't be down the we've heard enough already, when there are experts in the room, but we've heard enough, all of us this morning, to know that it should be kind of front and centre. Yeah. How do we link it to some of the things that are priority? I ask this of everyone. Is it about quality? Is it about patient care? Is it closer to home? What are the kind of big priorities that you could align this to, so it's not the sort of, someone somewhere is hopefully thinking about this, but it's not on my radar. What do we need to kind of align it with to sort of get it up onto the, the top? I don't know. There's probably hundreds of things. So, in the top 50, say.
I think you've partly answered the question in your in what you said there. I think it's about attaching it to that concept of care closer to home. That's definitely a big reform idea for the department and the whole system at the moment. And the second is that coordination of care, be that via or across the local health service networks. But there's an opportunity, I think, to take the coordination of genomic care to a next level, starting with the networks, but then, as Eugene said, thinking beyond that. So they're the kind of, and partnership, which kind of fits with that, they're the kind of big reform ideas. That's where the whole local health service network has come from, encouraging us to work together to think and plan services on a much larger scale rather than an individual health service level. And I think genomics is one area that could easily fit into that model. Having said that, Eugene's right. At the moment, this doesn't rank particularly high, so you do have to link it to some of those strategic goals and some of those areas of reform direction for the whole system?
I think that I agree with both these chaps. I think that for me it's ensuring that we just don't start doing a test and that's it. And then I don't have a workforce that's either credentialed or capable, because there could be some really complicated conversations that need to take place. So for me, there is a strong clinical governance that sits around this, but not to get in the way of innovation as well, because sometimes clinical governance and innovation sort of butt heads. So I think there's something, you know, around how do we build the workforce, referral pathways that are correct, relationships with pathologists, oncologists, all of those sorts of things. But it does need a level, I think, of early adoption the further out we go. And that might take a little bit of, let's give it a crack.
And you were saying before about you liken this a little to AI, the conversations being had around AI. Oh, no, don't mention
well, I mean, so I'll just remind you, I do the same level of compliance as both these chaps, but with probably a few less people around to do it. So, you know, if you go to Casterton, there's, you know, one person wearing about 5 different components of compliance. But I think that the key thing is that we do want to introduce new technologies as they come on board, but I want to build on good, solid old technology, or not old technology, but, you know, I need a good, solid foundation to add to. And when I worry about whether or not people are just getting breast screening, then I've got a lot to do before I get to this. But how do I keep it in the mix? You know, AI is the next thing. Where does that fit? Is it new techs? Is it IT? Is my alliance IT going to support AI? Is it not? So these are the sorts of questions we weave through every single day to try and make the path clear for these sorts of new ideas. But we have to be the sort of person that does say, maybe just hang on. Have we thought this through? And, you know, that's kind of our job every single day.
Do you have any thoughts on how we, and you sort of referred to it anyway, but it, you know, we've got lots of things that we're trying to sort of think about, Eugene. Where does this fit? How do we make it fit?
Well, I think if we aren't giving it our attention, it will continue to be niche, right? So how do we make it less a specialist sport? And it's easier for me to have that conversation because we're already in those swim lanes. Too many metaphors. However, there is therefore something about how we bring leadership to this. And, you know, maybe we've just got to accept in the here and now, it can't be everywhere, right? And in the areas that we have it, how do we make sure that it has the reach that no one's left behind? The cost versus value tension is one that we need to be a lot more honest about. Because the reality is we will absolutely say this is important, but when it comes to the allocation of resource, it's at the bottom of the pile. And therefore, that's something that we need more work on and ways of articulating the benefit. And interestingly, I think, and this is it controversial? I hope it isn't controversial. I think that if we can look at how the use of genomic care raises the game, particularly in those communities that are left behind because they're so far they don't have the capability, why don't we use that to bring equity to the treatment of certain disease conditions? Because if we don't, those communities are going to be left behind forever.
Rowena, you talked about that. That's a great point. You talked about that with a colleague from another rural and regional health service.
Oh, totally. And I think that's where we would be at, how we have that partnership again, have the conversation. Unfortunately, we do tend to be everything to everyone, but even as a sub-regional hospital, we do need to start to say, what can we do and do it effectively, because that thin ice is very thin some days. So I think it's important, but I think I have a belief in it, and I think the community also does expect me to be the type of person that will advocate for them too.
As you do. All right, I've been given the wrap up. We've only just begun. I've got so many questions, so I don't know which of those. Yeah, 2 minutes. So any final reflections with the 2 minutes to go? Any final reflections on what we've talked about so far that you might want to kind of leave everyone with? The people you can't see, Adam, what would you like to say to them?
I was trying to see if there's anyone here from the Alfred, but I can't actually. I can see some Austin and some Royal Melbourne people. What do I see? Despite the challenge around cost and the challenge around coordination across the system, what I think we need people to do is to passionately advocate for their service and the benefits that the advancement of that service will bring to patients in the community. And then we can work with those passionate clinical research leaders to work out how we join things up at a system level to do that. But I always try to say to people, however gloomy it looks like from a financial or economic outlook, we still need people to be passionate and put forward their good ideas. Otherwise, the system stands still. And genomics is an area where we can truly advance care. We've just got to do that in the right way.
Thank you. Rowena?
I would say to all of you niche people, next time you have a lamb chop or pop on your merino jumper, just remember there's a whole bunch of people out on the land who are responsible for that, and they deserve access to all of this. And so how can we work together to make it happen?
Here. We need to get better at walking and chewing gum, right? We can't have our focus just on today. And however challenging it is, we need to be spending some of our time, energy and effort in thinking how we can create the capability to look after people differently and better tomorrow. And genomics care is the bedrock of this, and therefore we need to be able to do both.
Great. Thank you very much. I hand back.